Hello and welcome to our webinar on chronic care management, Medicare and beyond. My name is Tammy Bauman. I'm with Great Plains Quality Innovation Network, and I'm a Quality Improvement Advisor on our Care Coordination team. Great Plains QIN is a Quality Innovation Network quality improvement organization for Kansas, Nebraska, North Dakota, and South Dakota, and we aim to achieve better health care, improved health, safer care, and lower health care costs. I'd like to welcome and thank our audience for participation today. We're very fortunate and have representation from a diverse mix of partners and stakeholders from our 4-state region. Today's webinar will be recorded and posted to our website at www.greatplainsquin.org. Please note it will take approximately 7 to 10 days to be able to access the recording. There will be an opportunity for questions after today's presentation, but please post any questions you have via the chat function. We'll be monitoring the chat feature through today's WebEx session, and Jamie Stagg will be our monitor for today. Objectives that we have for today are here, just to review the steps and implement a streamlined chronic care management workflow, describing recommendations to develop a multidisciplinary approach to providing chronic care management, relate impact on emergency room utilization and inpatient admission. So setting the stage a little bit, chronic care management services are provided by a physician or non-physician practitioner and their clinical staff per calendar month for patients with multiple, which is 2 or more chronic conditions, expected to last at least 12 months or until the death of the patient, and that the place of the patient is at significant risk of death or acute exacerbation. The included services are using a certified EHR, continuity of care and designated care team members, comprehensive care management and care planning, transitional care management, coordination with home and community-based clinical service providers, 24/7 access to address urgent needs, enhanced communication, for example, email, and advanced consent on decompensation or functional decline. In calendar year 2017, providers within the Great Plains QIN area had paid Medicare claims for over 37,000 months of CCM services. There are still opportunities to increase the utilization of these services, as you can see as the slide indicates. We do have some Nebraska speakers today. We have Ann Blanchard. She's BSN RN, is an intensive care nurse by background with over 13 years of experience in trauma and transplant. She transitioned out of direct patient care and was trained as a 6 Sigma black belt working in continuous quality improvement. Later moving into informatics as the manager, enterprise, ambulatory, and oncology clinical applications. For the past 3 years, she served in the role as Director of Primary Care and Immediate Care Clinics, utilizing her complement of experience and expertise to become a transformational leader in primary care. Gayla Hazenkamp is from the Cook Clinic in McCook, Nebraska, where she is one of 2 care coordinators. Gayla's varied nursing experience have given her a good knowledge base in many aspects of patient care, but her heart has always been led towards caring for the elderly. Gayla was hired to the clinic primarily to start the chronic management program. To date, she's enrolled approximately 119 patients in the program, and the benefits of CCM are being recognized by providers, nursing staff, and patients themselves. So, Ann, I'll turn this over to you.
Good afternoon, everyone. It's my pleasure to present our work on chronic care management to all of you today. Go ahead and go to the next slide. Thank you. So Nebraska Medicine. We are Nebraska Medicine and UNMC, so our mission is to lead the world in transforming lives to create a healthy future for all individuals and communities we serve through premier educational programs, innovative research, and extraordinary patient care. Our Nebraska Medical Center Hospital is ranked as one of the best hospitals in America and the best in the state of Nebraska. Bellevue Medical Center provides patient access to the same quality of care in a convenient local community hospital setting, and our ambulatory clinics include over 450 providers in 50 different specialty types. Next slide, please. Our primary care is really a robust network with 15 primary care clinic locations across the Omaha metropolitan area. Next slide. We are proud to have a patient-centered medical home, or PCMH as you'll hear me refer to it, model of care. PCMH is an approach to ambulatory care delivery that places the patient at the center of care. Patients are able to receive a full range of comprehensive services provided by a team of health professionals. PCMH provides a continuous relationship with personal physicians coordinating care for both wellness and illness. This is done through trust, respect, ongoing engagement, and shared decision-making with our patients. The result is an approach that allows us to proactively understand the needs of our patients and the population we serve. In January of 2018, the National Committee for Quality Assurance, or NCQA, recognized Nebraska Medicine Primary Care Clinics as a Level 3 PCMH, Patient-Centered Medical Home, the highest quality level of achievement. Our focus for today is on our chronic care management project. As you can see, we have a robust team with individuals across multiple different specialty settings. However, what you cannot see is the list of all of our collaboration and engagement with clinical staff and providers that was really essential to the success of our project. We began the project in December of 2015, and for some of you may be wondering why it took so long for us to achieve the results we have. I'm going to go through what our objectives were and the different pieces of our journey today. So our first objective was really to identify patients and create a new registry, and that is quite time-consuming with our IT division. The second was to create a consent form, build an electronic care plan, also build a process for all licensed clinicians in our primary care clinics to track and document their chronic care management time. And the fifth is to establish a standardized process across our primary care clinics to be able to bill for the chronic care management services that we were providing. Next slide, please. So what is chronic care management? It really is defined by CMS as the non-face-to-face services provided to patients who have multiple, 2 or more, significant chronic conditions. Providing extraordinary proactive care coordination between visits for chronic care patients is the goal of Nebraska Medicine. Continued partnership with our patients to optimize their health, increase their quality of life, ultimately preventing emergency room and hospitalization utilization. In 2015, Medicare began paying separately under the Med-8 Physician Fee Schedule, or PFS, for chronic care management services provided to Medicare patients with multiple chronic conditions, or the 99490 code. So why focus on chronic care management? CMS recognized chronic care management as one of the critical components of primary care that contributes to better health for individuals and reduced spending. CMS recognizes that about 93% of the total Medicare spending is on beneficiaries with multiple chronic conditions. As the population ages, our hospital, and quite frankly our primary care clinics, are faced with the daunting challenge of improving the quality of care we provide for more and more chronically ill patients while also containing cost. Spending and cost containment aside, chronic conditions such as type 2 diabetes, hypertension, obesity, and arthritis are a tremendous burden on our patients within the communities we serve. Next slide, please. So how did we get started? Next slide. So really, our objective, that first one, was to build a registry. So we worked diligently with our IT partners to build a registry that would automatically evaluate patients and their eligibility. Logic looks within our electronic medical record, first ensuring the patient is indeed still alive, has eligible insurance, and I'll explain that aspect further in a few minutes, and that the patient has at least 2 or more chronic conditions using the CMS rules as our true north. A chronic care management service consent form was created, along with frequently asked questions forms. Both of those are provided in an overview to educate our patients as to the nature of why we would want to enroll them in chronic care management. If you click again, you'll see the FAQ form. Thank you. Next slide. Our third objective was to build an electronic care plan for chronic care management within our electronic medical record, which is called OneChart. We named that the longitudinal plan of care. You see on the screen here a shot of what it looks like within our electronic medical record. And our longitudinal plan of care includes such things as whether or not the patient is enrolled in chronic care management, the enrollment information, recent and upcoming visits, goals, health literacy status of the patient, diagnosis, medications, and much more. Next slide. The fourth objective was really to build a process for all of our licensed clinicians in primary care to track and document their time spent providing chronic care management coordination to our patients. That really starts for us with our eligibility process being conducted at what we call our daily briefs. That's where our team all gathers in the morning and our nurse care coordinators are reviewing the schedule the day before to look at which patients are eligible for chronic care management and prioritize those patients, because we all have very limited resources, in looking at who has some of the highest risk stratification scores or historical care coordination needs. Our rooming staff, or MA, then notifies our nurses when it's a good time within the clinic workflow to have them come and speak with the patient regarding chronic care management. Our nurses then go over the FAQ form with our patients, the consent form, and then indeed do enroll the patients in chronic care management. Next slide. So this just shows you a screenshot of what this looks like within the workflow for our team members and what shows on the schedule. As you can see, creating functionality for the efficiency of our clinicians was really key. And so they simply can just double click on it and it will jump straight into the enrollment form. Next slide. The chronic care management process then shows that we really want to also identify what are the two chronic conditions that are of most concern with our primary care provider. Also, which clinic is this primary care provider at, and the name of the primary care provider. Once all of that is done, outreach is really what started now. So now that we've had them, we need to reach out to the patient on a monthly basis. And for us, any licensed clinician can conduct that outreach and document both inbound and outbound chronic care management time. So really, that's any of our PCMH licensed clinicians with the exception of our medical receptionist and MAs. It's definitely a team approach. Outreach process. Thank you. Chronic care management time documentation form. This just shows you our goal was really to not have our individuals within the team, our clinicians, have to double document, but simply to document the time they spent in the patient's medical record reviewing and the time they spent on the phone, either with the patient's guardian or caregiver, or coordinating their care. These screens are seen in a variety of different workflows for all of our members throughout the care team. Team members can document the time that they spent, whether it be on a phone call, within our OneChart patient portal, responding to email communications through that portal, or with insurance companies, anything that may be coordinating that patient's care. Next slide. This just shows you that once the 20 minutes of time, if we do reach that within a month, is collected, then the charge or the 99490 code is automatically dropped. It does not require a provider to have to do that, which was a huge win for our physicians. Next slide. Managers also were given a report to be able to track and see how their teams are doing specific to chronic care management. This is really just an opportunity for our managers to know who is left for outreach. We by no means want to arbitrarily try to reach a 20-minute threshold, and the communication with our team is always, we only achieve 20 minutes of time if it's truly meaningful for the care coordination of our patients. Patient Patient-centered goals are a huge initiative within our primary care clinics. With the patient care goal, chronic care management initiative is to move us from episodic rescue medicine to healthcare solutions customized to each individual patient, driving value and quality. Our primary care nurses, nurse care coordinators, are using the patient's medical goal set by the provider to engage the patient in creating their own patient-centered goal, customized by the patient for their unique lifestyle and behaviors to work toward goals that align care with what matters most to our patients. Identifying their personal health outcomes that they hope to achieve is really the focus of our chronic care management outreach. Next slide. We have a variety of stories that we could tell you regarding our chronic care management and the impact it's had on our patients. One such story is the one listed here, where our nurse Lisa made her outreach call and connected with a patient who was indeed having chest pain. The patient really was stating that this was no big deal, but our nurse completed her due diligence in requesting that the patient come into clinic that day, expressing the true significance of the chest pain. The patient did come in, and it was determined that she had changes within her EKG and was scheduled for additional testing. If we hadn't had called the patient for her chronic care management outreach that day, she would not have called us. This is one such example of a win to really keep our patients at the center of their health. Next slide, please. So, since December of 2015, our chronic care management journey has had many turns. Next slide. We are proud to be conducting more and more chronic care management outreach calls every month. What you see on the slide here is really just the number of outreach that is happening from one month to another. We then created reports for our managers and our medical directors to know how many patients they are enrolling from one month to another, the total amount of outreach that's been conducted, how many of those patients are indeed high risk, and how many have we actually conducted 20 minutes of time on those patients. Just to once again remind folks that it's not necessarily that we're meeting the 20 minutes of time, but truly that focus is on the outreach. Next slide. Oh, sorry, one more click. So how are we doing? We also pulled in reports to look at our patients. This is showing you data for our unique patients looking 6 months prior to enrollment in chronic care management and then 6 months after being enrolled in chronic care management. We really wanted to see the impact on both ED utilization and readmissions. And we are very proud to say that we've seen a 23% reduction in both ED utilization and, if you click again, for readmissions, 23%. Oh, that must have just combined there. Sorry about that. So where are we going? Okay. We are focusing our goals on increasing our chronic care management enrolled patient outreach to exceed 50% across all of our clinics for 3 consecutive months. Also increasing chronic care management enrolled patients by 25%, and implementing the 2 complex chronic care management codes, the 99487 and the 99489. Both of those have been built within our system, and we are conducting education to our teams at this time. Our future. Our PCMH Medical Director, Dr. Stephen Mooring, has stated there's simply no initiative that has a greater potential impact to inter-visit care for our most at-risk patients than chronic care management. It is a huge win for our patient satisfaction, improvement in chronic disease care, and proactive management on the part of our clinical staff. Primary care's goal with chronic care management is to once again move us from an episodic rescue medicine to healthcare solutions customized to each individual patient, driving value and quality, resulting in improved outcomes for our patients and the entire community we serve. Thank you.
Thank you so much, Ann. And again, if you have any questions, please go ahead and put those in chat right now. Let's see, Gayla, we will move on to your slide. So go right ahead.
Okay. Hello, everyone. My objective today is just to share our story with chronic care management from the perspective here at McCook Clinic. We didn't have a lot to start out with as far as any guidelines to go by other than what we read. I started here at the clinic a little over 2 years ago, and a couple months after I started working on the chronic care management program. I had no experience in it, as did no one else here, so it was a little bit of a struggle, but not really as difficult once you look back as you thought it might be. I feel like it's been a very rewarding process, personally and professionally for me. Our providers and patients have noticed a difference in their care and the delivery of care here since we started the chronic care management program. So I feel it's beneficial to both the patient and the practice as a whole. A lot of this will probably be repetitive from what Ann has said as far as what is chronic care management. You can go to the next slide. Services provided by a physician or non-physician practitioner and their clinical staff during a calendar month. And as she defined, the chronic conditions that last greater than 12 months that place the patient at risk of exacerbation, decompensation, functional decline, or death. Next slide, just some examples of chronic conditions. And of course that can be, depending on the person and studying their history, but I've found that, most all of our Medicare age folks, it's not a problem to see most of them qualify for chronic care management. So any of the dementia, Alzheimer's, that kind of thing, arthritis, asthma, atrial fib, cancers, cardiovascular diseases, COPD, depression, diabetes, hypertension. Those are some, and there would be more. So our goals of the chronic care management program, coordinate their care between ourselves here at McCook Clinic, any specialists that they might see, any outside services, DME providers, any of those people that are part of the patient's overall health care. It minimized hospital stays and ER visits. Our hospital, I asked for a recent readmission rate, what they're seeing. I did not receive it in time today to share that with you, but it has been gradually going down. They've noticed, they've been watching that, and I've met with them a couple times to watch those numbers and see how we can collaborate together. I have made a referral sheet also if the home health staff that is part of the hospital staff here, if they run across a patient that they think would benefit, they can fill out a referral form for me. We have EMTs that do a special home visit program also. If they run into anybody, they can refer to me also, and we can investigate and see if they're indeed someone that qualifies. It just empowers the patient to reach their health care goals, improves and maintains continuity of care. I watch for preventative care and lab services that are needed, review charts. Many times the providers, they've got many irons in the fire, as we all know, and just having somebody else look over that chart and see, take a look at your patient, see if they're on a statin, when was their last lipid panel, they're diabetic, are they due for a hemoglobin A1C, so that those things are not overlooked. So then if I notice that, I just send a note to the provider and remind them of that and ask them if that can be ordered. So we just hope to keep more patients well more of the time, and as I mentioned, hopefully keep them out of the ER unnecessarily and limit or reduce readmissions to the hospital. And then the qualifying factors and patient eligibility. At this time, I have not started doing any of the Blue Cross, Blue Shield chronic care management. I hope to do that here shortly in the future, and we'll learn more about that. There's a lot about it that is the same as the Medicare qualifications. Um, so we look right now at the chronic conditions, if they are a Medicare recipient, if they've had a face-to-face visit within 1 year with their billing provider, and then the face-to-face, we typically sign our people up after they've had an office visit face-to-face with their provider. Depending on if you are a clinic that is involved in the CPC Plus program, then of course that affects your billing, and that's a whole another discussion. But if you were able to bill, you can also bill that GO 506, which they changed, I believe, at the first of last year, which was nice because at that time you didn't get a lot of reimbursement for the time that you spent writing a care plan and getting your patient qualified. And so you can do that initiating visit as separate from the CCM service code of that initial sign-up day. And then other qualifying factors, the patient consent. It is not a requirement that you have to have written consent anymore, but we continue to do written consent just so we have documentation of that. And that just helps when you're sitting with the patient and talking to them. I can go down that consent and make sure that I have explained all the different facets of chronic care management to them. It only needs to be obtained once per billing practitioner, and it just kind of helps inform and engage the patient in the program and give them another opportunity to have any questions answered as you go through that consent. And you also have to have your structured recording of patient health information, typically via the EMR. Then you develop the care plan for the patient. You want to have attainable goals, what their diagnosis. So typically I at least care plan three chronic things on most all people, have enough to do that. So otherwise, if they just have the 2 chronic conditions, I do that. And I also write a care plan on every chronic care management enrollee on med reconciliation, and make sure that I do that as often as possible with them. Sometimes that is not possible to do right with your patient. So I'll call the pharmacy, have them send me a med list. If the patient gets bubble packs, that kind of thing, all the pharmacies here are very willing to do that. So that satisfies that requirement. So set your goals. I include any outside services that I'm aware of with the patient. When I initially sign them up that first day, I ask them questions about that. If they receive any outside services in their home, Meal on Wheels, if they have a Lifeline emergency button. If not, do you have a cell phone with you at all times or a phone at your bedside? How do you do your meds? What assistive devices do you use? Maybe ask them some questions about safety issues in their home. And write up your care plan, and then you need to give a copy of that to the patient. The patient also needs to be able to have 24/7 access to their provider and or a care coordinator. Depending on your facility, that can be satisfied in a number of ways. Most places have someone on call all the time, and that person needs to be able to access that care plan and the chart of the patient to be able to effectively treat them and know what their goals are and their current issues. And then just other service elements. Most always it's supposed to be non-face-to-face encounters. I believe the wording is, anything that you would, if it's something that you would typically do in an office setting, that it doesn't count towards your minutes. So I myself have made home visits to set up medications. Even one occasion I had a lady that I went to do that, set up her meds, and it was later in the afternoon on a Friday, and she was having issues, and so I drove her back to the clinic to be seen. So those minutes count, and it's sometimes those above and beyond things that really help, like the story that Anne shared with her nurse. I always encourage my chronic care management patients, if they have any issues, if they happen to call in to the schedulers and they're not able to get an appointment, secure an appointment to see their provider as soon as they feel they need to, they should be sure and call me. I do have a lot of my chronic care people that I think pretty much just call me for everything because I have a dedicated line, and so that really helps. They don't have to wait. I'm at my desk, the greater share of the day, so they're able to get a hold of me right away and can, they'll even call me with questions about when is my handicap parking sticker coming, anything like that I may have not been involved in from the get-go. Might have been their PCP and the PCP's nurse, but I can answer those questions and save some time for the physicians and mid-levels and nurses by taking care of some of those details. So you can share your care plan with appropriate entities also. And I also track any care transitions on my chronic care people, watch for them to have hospitalizations. Sometimes you don't know about that until it's all over and done with, any ER visits. I review their chart and see what notes we've received from any specialist visits, referrals, if we've completed closed the loop on referrals with them. So just watch some of those things in addition to needed labs or any testing that might be done. They also receive from me educational materials on the diagnosis that we have chosen to focus on and care plan. I give them written material. I only have a very few of my patients that are actually on the patient portal, partly because of their generation, their age. A lot of them don't have access to that. And so I give them, if they don't, paper copies of any kind of educational materials, and I encourage them down the road, anything that they need to reference or be educated on, we can access some materials for them. I always tell them right from the get-go, of course, that the program enrollment is entirely voluntary, as is discontinuation, and I tell them that if they feel that it's not beneficial for them or it's, intrusive or whatever the case may be, they don't have to give me any reason. They can just tell me that they're, no longer interested. I've only had a couple instances of that, and I think it ended up being people that I really don't think would have probably in the long run benefited from the program anyway. I have the provider choose the patients, and that kind of helps ensure some buy-in from the patient also, because I'm able to tell them that your provider chose you for this program. They identify the potentials and help me decide what diagnosis is an issue that we want to focus on for care planning and addressing down the road. So kind of the process from the get-go is identifying those qualified people. We have all scripts for our EMR, and I can run a report, and what I do is usually just plug in 2 or 3 chronic diagnoses and run a report on people that are Medicare recipients that have those diagnoses, and then I give those out to the providers and have them mark people that they feel would be appropriate, and if there's anyone that they absolutely feel for whatever reason would not be appropriate, to cross them off for me also. Then I take that list and look at those people, and I check for upcoming scheduled appointments, and then I give myself a calendar flag on those so that I know when they're coming in, or if it is someone that hasn't been scheduled for a long time and really needs to get in and be addressed, then I can call them and schedule if need be. So then if I do see that they have a scheduled appointment, what we do is we flag the super bill or flag the chart, whatever works for your practice, and or put a note in your scheduling to alert the primary care provider and or the nurse that you want to visit with that person. So the way it works in our clinic is the provider would go in and do his usual encounter, and then he or she briefly visit with the patient and explain just kind of in a nutshell what chronic care management is, and that he'd like them to visit with me. Unlike some of the bigger clinics right now, I am the only one that does chronic care management here in our clinic. So they get me and I come in and visit. I take a consent in with me, explain in full the program, and sign the patient up if they're agreeable. Talk about them with them about care plan goals, and get the consent if they do agree, and tell them they can call me. I do not, since it is only myself, I do not typically schedule certain times to call them. Especially in the past, I haven't, because I had several other job duties, and just recently I'm going to have pretty much 100% of my time as chronic care management. So I may look at that differently in the future and do some scheduling to be able to catch people better. But you kind of learn your folks and know that who goes to the senior center every day for lunch, that kind of thing, when they're going to be available and when they're not. And I always highly encourage them to call me also, that it's not just me reaching out to them, that it's a two-way, that they can call me with any question, no matter how small or how trivial they think it is. That's what I'm there for. And of course then I document that initial visit in the medical record. And we have built into ours, we have a time log that I can go in and click on, and the nurses can go in there if they choose to, if they call with lab results, that kind of thing, call the patient. And we have a encounter instead of just a normal office encounter for my calls and for my initial charting that's called a chronic care management encounter, and the charts can be signed off in that fashion. I always have forward the chart back to the provider and have them sign it off so that they are aware of what I visited with about the patient about, so there's no surprises, and they approve of any suggestions that I have given the patient. So the calls to the patient, the follow-up calls after that initial sign-up day, just I go in and I review their chart, see if there's anything that I'm not aware of, any specialty visits, their last office visit, take a look at that and refresh your memory on what was going on with the patient, so you can ask them about that issue that maybe they were seen for that day. So just the basics, identify yourself and tell them why you're calling, that it's chronic care management, follow up on any issues. I look, when I'm reviewing the chart, make some notes, certain things that I do want to ask the patient. And on that initial sign-up day, I have also maybe made note of the fact that the patient checks their blood pressures at home or their weights, that kind of thing, any home monitoring, so I can ask them about that. Reconcile their meds in whatever fashion is appropriate for that patient, whether it be with them or with their pharmacy or with their assisted living staff. I always confirm any upcoming appointments that we have on the books for them, remind them of those, and if they don't have any, schedule future appointments if need be. Remind them to call with any questions or concerns, and of course thank them for their time. The next screen there is just an example of the flow sheet time log that's in our chart. So that's just kind of how it looks, and it is there, and the entries always stay there. You can pull it into your visit note if you would like to, or just it will still remain in the chart as is if you don't want to pull it in. So I always, on my documentation of every call, I pull in the applicable diagnosis, typically the ones that I've care planned, their allergies, and then just document all the details of the call and conversation. pull their meds in, reconcile those. I go in and update the care plan, and then, like I said, each one of these notes also I forward to the provider for sign-off. You'll note there it says addendum page 4, and some of those addendums I don't believe are included in the slides, and that was just an example of some charting. And then, as Ann explained, the codes, so I really don't need to go through all those. That GO 506, I believe she said they're working on bringing that in, and that is the one that can be billed on that, in addition to the office visit, that first day for sign up, and that helps get some reimbursement for the time that has been spent developing the care plan and such, and qualifying your patients. And that is a one-time only billing per practitioner, so you cannot bill that with any other CCM code, and you would only bill at that initial time, is my understanding. The next page is just the typical codes, and so those are pretty self-explanatory. I have used the add-on codes a few times. You have to do some extensive care plan updates, and there's on the CMS sites, there's, define exactly when an add-on code should be used. Keep in mind that if you're doing transition of cares, that cannot be billed within the same time period. But of course, chronic care management is a calendar month, and then whereas transition of care is a 30-day window, so you have to be careful that those times don't overlap. And then just depending on what your billing system is, if you have a paper form or a electronic form and the time log, submit that to billing. And again, like I mentioned earlier, billing is a whole different procedure when you're on the CPC Plus program. I have, like I said, I think I have 5 or 6 people that are not on our attribution list that I can bill for. The slide that has the chronic care management process snapshot, that just starts at the top and kind of walks you through. You look at your list of potential enrollees. You have the provider pick people that they feel would benefit from chronic care management. Check for appointments. Flag your chart or charge ticket, however you would do it, or your schedule. Present the program to the patient. Obtain consent. Develop a care plan. Give the patient a care plan copy and your contact information, of course. And document and flag your chart. I flag my charts that is the CCM patient, so that anyone from billing to the administrator, anyone, when they open it up, they see that flag pop up. And have the primary care provider review and sign off your notes. Keep up regular patient communication. Log your call time and document the details of those follow-up calls, and bill when applicable, and repeat the process. And I believe that is all I have.
All right. Thank you both so very much. That was excellent. We are going to get to questions here in just a minute. You had resources there. I wanted to go over quickly that we have some upcoming events that are also on the slides. And then our contact information here for the states. And I will leave it on this slide for any questions. And Jamie, I saw chat had a ton of questions for Ann and Gayla. You want to start?
Yes, appreciate everyone asking their in chat, and can continue to ask them if you have them. We'll do our best to get them covered here in the time that we have remaining. Our first question that I see is a question regarding whether or not anyone is billing CCM codes in a provider-based clinic with Method 2 billing. So I'm not sure if we have any responses for that.
So I guess I'll take a shot at that one. I'm not sure if I'll best be able to answer the question, so we might have to have a repeat question. But we are billing for chronic care management across our primary care clinics, and so included both for Medicare, and we've also extended it to our Medicaid patient population, and then also through Blue Cross Blue Shield, value-based contracts, and our employee health plan that's under UMR. Hope that helps.
Gayla, do you have anything for her?
I would say about the same. We're just doing the Medicare right now, but we'll be adding Blue Cross.
Okay.
Our next question is kind of a couple of questions here related to when you started your program. So the question is, how did you decide patients to include it first, and then wondering if it was the top 50 or 100 users of the system, or did you just enroll anyone that was eligible? And then also with that initial start, how did your coordinators keep up with the potential number of new cases that enrolled?
For Nebraska Medicine, we took a process where we started rather slow, if you will, and it is that aspect where we do still require consent, similar to what Gayla was alluding to. It's no longer required by CMS. However, it really is something new to our patients that they may be billed for care that they aren't face-to-face with, so the chronic care management being that non-face-to-face. So we want to ensure that the patient has been into clinic, we've had the conversation and discussion, they've signed the consent, as well as have the FAQ form. And so for that, we really are focusing on what patients are coming into clinic that are our highest risk patient population or rising risk. And so we have that discussion with our care team at the beginning of clinic. If we have multiple patients that are coming into clinic and the nurse, as happens, is not able to get to all of them or is derailed by another urgent situation, we really then focus on those highest risk patients and the ones that the providers are most concerned about. So what we let our teams know, if they have 50 patients coming into clinic today that are eligible and really are ones we want to focus on, however, they're not able to get to all 50, how do we really focus on those highest risk patients?
At McCook Clinic, the question said, how did we decide to include? Again, I limited my numbers by just plugging into my report a couple diagnoses. So like maybe the first time I ran a report, I put in diabetes and CHF and pulled all the Medicare recipients with those diagnoses. And of course, there's a lot. And but then had the, ask the providers to go through and pick the people that they really, felt like needed someone to help manage their health care. So they chose them in that fashion, and it was just me, and so we, like I said, working on it, and so I go pretty slow and just put those people on a calendar myself that are as their appointments come up, and so usually I haven't had many in a day that I deal with enrolling new ones, because then I'm the one that's also making all the follow-up calls. So
that piece of the outreach and the follow-up calls has been one of our biggest lessons learned at Nebraska Medicine. It really is a new piece of the workflow for our care teams for that proactive outreach. Our teams will document and note different aspects of patients calling in the inbound, but the outbound is really making sure that we are reaching out to each patient that's enrolled at least once a month and connecting with that patient and checking on that patient. And so with that, that's been a new piece that's been added to our nurses' workflow, and they review a report that shows them all the patients that are enrolled for their provider that they're collaborating with, and they're really trying to schedule a little bit of time either throughout each day or a couple different times throughout the week that is dedicated to outbound care coordination calls.
And your primary care providers, primary nurses, floor nurses, so to speak, they are the ones that do your calls as opposed to just a dedicated care coordinator nurse, or?
So our nurses within our primary care clinics are our nurse care coordinators.
Okay.
We do not have RNs that are per se in the clinic and on the floor. Our PNs and MAs are the ones that are within the clinic workflow with that direct patient care for the most part. Our RNs are our nurse coordinators, and they are the ones doing the bulk of this work. We do also have times where our LPNs are part of that collaboration effort as well.
Okay.
Okay. Next question is, what elements are included in your electronic care plan that's required, and are your goal areas allowed to be customized? And how do you get a patient a copy of this to meet that requirement?
Here at McCook, I guess as far as elements, pretty much typical, a goal, any barriers to that goal, if it means, in regards to their medication, if finances are a barrier, if transportation is a barrier, put in those kind of things and possible ways that you can get around that, and what actions you're going to take, if it is something that you can put a time frame on, or if you have a specific goal for what you want their blood pressure to run, getting their hemoglobin A1C down to an acceptable range, specifically, and our physicians usually document that in the chart, to kind of individualize to the patient that, maybe this patient, we just hope to get him down under 7.0 for a hemoglobin A1C, whereas another individual, maybe their goal is 6. So I put that in the care plan. And if I am unable to, complete the care plan while they're still here in the office that day, I sign them up. Sometimes they're in a big hurry to get out, or I have, questions I need to talk to the provider about and maybe things to iron out. I put it in the mail right away to them then with some educational materials and another copy of my contact information that has my direct line number, that kind of thing.
At Nebraska Medicine, our care plan is within our longitudinal plan of care. So our clinicians do not document directly into the longitudinal plan of care. They document within their normal workflows and screens, and then the information is then populated to the longitudinal plan of care. The information that's contained within that plan of care was specifically identified and called out to meet all the requirements of CMS. So there's things such as the patient's care coordination notes, who's on their care team, future appointments, the current problem list, upcoming health maintenance such as mammography, colonoscopy, those sorts of things, their current medications, goals, also any health or social disparities such as health literacy status, the medical goal, patient-centered goal, and chronic care management enrollment status are all aspects that are populated to the longitudinal plan of care. The patient receives the information on their care plan after a visit in what we call their AVS, or after visit summary. Our patients that are connected to us electronically through our electronic portal, known as One Chart Patient, can then view their longitudinal plan of care electronically in that format, and we can also print off, if they like that view, a printable version of their summary.
Thank you. Another question is, how often have you had CCM patients call after clinic hours?
Quite frequently. So for our Nebraska Medicine, we have a medical call center that answers after-hour calls from patients. And so they address those immediate needs and triage patients. If the patient has questions or concerns that can wait until the next day, they send an in-basket message to the daytime clinicians, nurses, and LPNs to connect back with the patient the next day, at which time we would reach out to the patient and coordinate their care, documenting that time that was spent.
In my case, I really have not had very many. You know, I'll occasionally have a message. Otherwise, calls are directed through our hospital, which is a separate entity from us, but physically the buildings are connected, and our physicians are the ones that staff the ER 24/7, so they can call there also with questions. And so some of those I may not get relayed to me all the time, but I really have had few instances of having folks call in.
I think maybe this was mentioned in the presentation, but the question was, how frequently do you call the CCM patients? Is there a minimum number of times, or is it individualized to the patient?
For Nebraska Medicine, it's definitely individualized to the patient and what their care collaboration, care coordination needs are for that month. We do have a goal of at least one outreach to the patient on a monthly basis, but that is meant to be an outreach to connect with the patient and ensuring that we're coordinating their care, but by no means an attempt to reach the 20 minutes of time.
I agree with Anne, and as I mentioned before, my time has been freed up here just in the last couple of weeks. We had another care coordinator start here at the clinic, and so I'll be able to do close to 100% of my time on chronic care. So I do have some people that are very difficult to reach, sometimes don't return messages, and I have just a friendly letter that explains again to them the purpose of chronic care, and that we hope to continue to provide this service to them, and reminding them of my contact information. And I think that is, with a couple individuals, kind of open communication back up. Depending on the person, some of them, you have to remind them who you are and exactly why you're calling, and identify, because they get used to the provider's usual nurse. And so I have to remind them that, I too am a nurse here at the clinic, but I just work for all the providers, and kind of refresh their memory sometimes of why you're calling. So I hope to step up my contacts too. So mine vary quite a bit and are also individualized to the patient. I have some people that I talk to, weekly, and a lot of them call me frequently also, so.
Thank you guys both so much. We have more questions, but what we'll do is we'll compile the questions. We'll get Anne and Gayla to answer all of them, and then we will send those out to all the people that registered for this webinar. So again, we want to thank Ann and Gayla so much for providing their expertise in utilizing CCM. We're asking all of you to complete the evaluation form for today's event to offer us feedback and help us plan and coordinate future events. Your input is very important to us. Please use this evaluation to give us those feedback on the types of topics you want us to address as well. The evaluation should appear when you exit today's webinar. Please feel free to contact us here at Great Plains Quinn Medication Safety Leads with any questions. Thanks again for your participation today, and we hope you found it very informational and valuable and applicable. And this concludes our webinar.